It's a pleasure to have Mohammed Al-Damlui, who's one of our excellent interventional fellows. He's going to present the one-year outcomes of the DEFINE-PCI study, which is a study of IFR and IFR pullback and in relation to angiographic stenoses and outcomes. Thanks a lot, Mo.
All right. You can hear me and you can see my screen.
Yes, I can.
Yeah. All right. Good morning, everyone. Today we're going to do this report, one-year outcomes of blinded physiological assessment of residual ischemia after successful PCI. DEFINE-PCI trial, this is the one-year follow-up by Patel et al. This was published January 2022 in JAC Interventions. So let's get into it. As you all know, patients with a stable ischemic heart disease and some patients with who present with acute coronary syndrome, the use of physiology has been established to help us decide who should get revascularization. And the most commonly the most established index is the fractional flow result, FFR. At this point, operationally, we're using the cutoff of 0.80 for this index to determine who we should give an intervention to or safely defer an intervention. It's a hyperemic measure, so it requires the use of vasodilators before we measure this index. Like every interventionalist should ask himself or herself as we perform PCIs, how do we optimize our intervention, and will we give our patient the maximum benefit of our intervention? The most common way to do that at this point is using intravascular imaging in the form of IVUS or OCT, but we need to know that there are many studies in the past that looked at post-intervention FFR, and that was showed to correlate quite well with clinical outcomes. Here I'm showing you the results from Rimac et al. This is a meta-analysis of 58 observational studies that reported post-intervention FFR. In that study, they dichotomized people by an FFR of 0.90, again, post-intervention. And you can see, compared to the patients who had post-intervention FFR less than 0.90, the patients who had an FFR more than 0.90 had lower repeat PCIs by 57% and lower MACE by 29%. So despite of that, the use of post-intervention FFR is not commonly performed. Another index over the last few years that was introduced and being used is the IFR. One of the main advantages of this index is it's not hyperemic, so we don't need to use medications like adenosine that can potentially give patients some uncomfortable symptoms such as shortness of breath, flushing, etc., or even clinical events such as arrhythmias and heart blocks. This index doesn't require the use of that, and it correlated quite well with FFR in two large clinical trials. Here I'm showing you to the left the DEFINE-FLAIR clinical trial, and to the right, the SWEETHEART. Both of these clinical trials showed quite good agreement between the two indices. And we're using the cutoff of 0.89 to determine when to revascularize versus to defer treatment. Another advantage of the IFR, we can perform a pullback technique when we have a vessel that has multiple lesions or tandem lesions. And we can tell the significance of or the degree of contribution of each lesion physiologically as we perform this pullback technique. So here, this is an example from a paper that I read, Niger et al. You can see a right coronary artery. The operators placed a physiological wire distal to the last lesion. You can see that this vessel has multiple lesions in tandem, and they got an IFR of 0.85 for this vessel. And as they performed the pullback technique, you can see here a graphical representation of what happened. So they started at an IFR of 0.85, and as they are slowly pulling back the wire, you can see the line is going up, and this tells you, like, the contribution of each of these lesions to the change of the IFR, and it co-registers to the angiogram. So this is like available to us at Yale New Haven, and also at the VA. Hopefully, we'll have it at SRC. And here, the writers of the paper, they also go through the exercise of if we fix only the first lesion, then the predicted IFR will be 0.90. If we fix just the second lesion over here, then the predicted IFR will be 0.88. But if we fix both both lesions, then the predicted IFR will go up to 0.94. So this, the software also gives you that, and it gives you a representation of it, over here by dots. Each dot is 0.003 of IFR. So it just tells you how much each lesion contributes to the change in IFR. So just before,
so Mo, you showed the the define, was that define flare was the name of the,
yes,
right, of the. So I think there's a lot of studies showing agreement with IFR and FFR, but the main goal of this define flare and all these studies is to show that with IFR you get the same benefit of reduction and and using a cutoff and reduction in cardiovascular outcomes. So that's more like validation of the technique with outcomes more so than agreement. So I think just to make a little clarification there, that was the study. Are you aware of anything with the IFR pullback and improvement in IFR and relationship to outcomes in any way?
So so there are some. So this study that I read over here comes from Imperial College. It was published in 2015. It goes over the. It sounded more like a mathematical exercise of looking at it, but to be honest, I didn't find anything that that was clinical data to validate this measure. But so to be honest, I don't know.
Yeah,
so I didn't
come to that in the discussion as well.
Right. All right. I think that's right. I think these basically, you've shown that these papers shown that the technique works in terms of predicting the IFR before and after, but there haven't been. I'm sure you'll discuss it. There haven't been studies, randomizing someone to a pullback-based PCI approach or spot IFR only. But Karthik's right. Those two trials did look at outcomes, and before the trials were done, there was a bunch of studies done just looking at correlation, which is an important distinction.
Right. Yeah. And yes. So the DEFINE-PCI study, this was published in 2019, JAK intervention also. So when it comes to post-intervention IFR, there is still so much that we don't know. There are a lot of gaps in knowledge. And the DEFINE-PCI study wanted to prospectively look at the proportion of the patients post-intervention who have abnormal IFR. And within that subset, they wanted to look at the etiology of why that is. So and I'll go over the details more in the methods, but they prospectively recruited about 500 patients, and they investigated the vessels of interest with physiology. And when they decided that the patient required an intervention, they asked the operators to perform the procedure. And when the operator felt that the procedure was adequate, they performed an IFR pullback that was blinded to the operators. And you can see in this report in 2019 that 1/4 of the patients had an abnormal IFR post-intervention after the operator felt that the procedure was adequate angiographically.
No, this is a multi-center study, correct?
Yes.
It's
yes.
the United States and Europe.
I'll get to it in the methods. Yes.
Okay.
I'll get
right.
Yeah. So 80% of those 25% patients had a focal lesion that the low IFR was attributed to, and 20% of them had what was described as diffuse disease. So this is the main finding of the initial DEFINE-PCI study. Now, our current study uses the same data, and now we're reporting the 1-year follow-up. And what this study wanted to achieve, first, it wanted to identify a post-PCI IFR target that would best discriminate clinical events. And then, based on that, we're going to describe the post-intervention clinical outcomes. So now I'm going to go over the details of this cohort. So first, the DEFINE-PCI is a prospective, single-arm, and blinded multi-center study. As Karthik said, it was performed at 28 centers, and these centers were all in the United States and in Europe. The inclusion criteria for those patients were patients with stable or unstable coronary artery disease. Just for the patients who had acute coronary syndrome, for them to be included, they have to be more than 1 week from the event, and they should have TIMI-3 flow in the blood vessel of the interest before they can be included. Then they performed the physiological assessment, and if the vessel was like, it showed like, ischemia, then they were included. And the vessels that were included were single vessel, which had multiple lesions, at least 2 separate lesions, 10 millimeters apart, and these lesions had more than 40% stenosis, or a single vessel disease with long lesion of more than 20 millimeters, or they had multivessel coronary artery disease. The patients were excluded if they had recent MI, as I said, within 7 days, if they had ventricular arrhythmias, if they had cardiogenic shock. They excluded patients who had chronic total occlusions, or if they had an EF of less than 30%, or patients who had previous CABG. They excluded patients who had severe renal dysfunction. And they also excluded any patient who had a medical condition that would limit the life expectancy to less than 1 year. The wire that was used in this study was the Verata wire, or the Verata Plus, by Philips Volcano. They had a standardized protocol for the study. So all of these pressure wires were normalized at the aorta, at the ostium of the coronary. And then once they did the normalization, that they gave everybody intracoronary nitroglycerin at least 200 micrograms. Then the wires were positioned in the distal third of the vessel. A resting IFR of less than 0.89 in at least one vessel was like, needed to enroll the patient. And if they find a multivessel coronary artery disease, then all vessels is to be treated. So the patient gets included, and they don't so all of the vessels needs to be treated if 2 vessels are physiologically significant by the IFR. And then they let the operators perform a PCI based on the practice of the center. So all of these PCIs were done angiographically, with some centers using intravascular images. IFR pullback before the intervention was not allowed. And once the PCI was done and the operators thought that they were satisfied with the work that was done, and they felt that the PCI was adequate, at that point the pressure wire, if the pressure wire was used to do the intervention, then it was reconnected. If the pressure wire was removed and they used a workhorse wire, then the pressure wire was re-advanced again. And then they blinded the operators to this pullback IFR. So all of the screens in the cath lab were turned off, and they had unblinded research staff that recorded the result of this blinded IFR that was done after the procedure. Then once the data was acquired, this data was sent to 2 labs, Physiological core lab, that assessed the waveform from both aorta and the coronary, and they made sure that there is no distortion in the waveform, there's no aortic ventricularization, or there's no drift. And they looked at the post-intervention transstenotic pressure gradient. And if there was a pressure gradient, they looked at the location of the pressure gradient. Did it happen at the distal vessel, or did it happen in the stented segment? And this includes 5 millimeters distal to the stent and proximal to the stent, or proximal to the vessel. And they also looked at the pattern of the disease that caused this abnormal IFR, be it either focal, which was defined as change in IFR of 0.03 in the segment of less than 15 millimeters, or diffuse, which is more than 15 millimeters. That's the definition that they used. They also sent the angiograms to an angiography core lab, and that was assessed for residual lesions of more than 30%. The physiological core lab was blinded to the angiography data, and the angiographic core lab was also blinded to the physiological core lab. To the physiology results. So both labs were blinded. The clinical endpoints for this study that we're going to present today is periprocedural or spontaneous MI, target vessel revascularization, and cardiovascular death. They also looked at the Seattle Angina Questionnaire, the angina frequency score, and they looked at it at baseline, at 1 month, 6 months, and 12 months. And this is the results of the study. So they said to include 500 patients, and they were able to enroll 500, but about 20 patients were excluded because either they had clinical instability, or they couldn't pass the wire, the pressure wire, or they didn't have adequate recording. And then, so that left them with 480 patients. They had 535 vessels of those 480 patients. Another 15 vessels were excluded because of drift or waveform abnormalities. So in the end, our final cohort was 467 patients, 520 vessels in those 467 patients. The first thing that they did was they drew a receiver operator curve. You can see the y-axis of this graph is sensitivity, the x-axis is 1 minus specificity. And based on the clinical outcomes of cardiovascular death or spontaneous MI, they were able to determine that the best cutoff to differentiate clinical outcome was an post-intervention IFR of 0.95. And that gave them an area under the curve of 0.74. So so good, but not great. But this is why they use this cutoff of 0.95. So once they determined that the cutoff was 0.95, they presented the baseline characteristics of the cohort based on that IFR. Again, we had 467 patients. 285 patients had an IFR, post-intervention IFR of less than 0.95, and 182 had post-intervention IFR of more than 0.95. The baseline characteristics were quite balanced between the two groups. The only difference was BMI was a little bit higher in the patients with IFR less than 0.95. It was 30 versus 29. That was the only one that reached statistical significance. The rest were basically the same. Just to highlight a few important baseline characteristics.
So this 0.95, is that from prior data? Or
no, this was based on the receiver operator curve that they drew, and they use an area under the curve to determine this cutoff.
Let's see.
Okay. Yeah. So 3/4 of this cohort was male. The average age was 67. The distribution of certain important conditions. So 1/3 of the cohort had diabetes. 3/4 of the cohort had hypertension. Dyslipidemia was at around 70%. Most patients didn't have renal disease, but as I told you in the exclusion criteria, they excluded patients who had GFR less than 30. The mean ejection fraction was 56%, but again, they excluded patients who had ejection fraction of less than 30. And then for the presentation, 42% of the patients presented with stable angina, and 30% of the patients presented with unstable angina. And then there's smattering of the rest. But most of the patients presented with either stable ischemic heart disease or unstable angina. There's few patients who presented with NSTEMI or STEMI. So here they're presenting the Seattle Angina Questionnaire. They looked at the angina frequency tool. And just to explain to everyone, so this is a scale that goes from 0 to 100. The higher the score, the better it is. Patients who reported a score of 100, that means that the patients didn't have any angina. If the score was between 61 and 99, then those patients were reporting angina in a frequency of once a month, in monthly. Between 31 and 60, then those patients are reporting angina at a weekly basis. And then less than 30, then those patients are usually reporting angina daily. Again, there was no difference between the two groups at baseline when it comes to the baseline. Yes.
Sorry to interrupt. I don't mean to interrupt so many times, but what was the take home from the initial DEFINE-PCI study, not the 1-year outcomes? Like just a few lines for everybody. So then we sort of have a segue to go into the 1-year outcomes.
Yes. Let me go back to the figure, because I'm kind of visual person, so it makes it easy. Yeah. So first of all, I just want to remind everyone that the IFR pullback was blinded to the operators, and the operators felt once they finished placing the PCI, and they felt that the PCI was adequate. We found that 25% of the patients had abnormal IFR post-intervention, and post-intervention, within this subset of the patients who had abnormal IFR, 80% of them had a focal lesion, which raises the question: is this an actionable lesion? Can we post-dilate the lesion if it happened within the stem segment? And if the lesion was somewhere else away from the distal, from the stent segment, then say proximally or distally, should we go and like, add a stent or like, fix that lesion? Questions that remains after this study. Another important finding from the initial study was there was like poor correlation between the angiographic result and the post intervention IFR. So these are the main findings that came out of it. Now, again, like the operators were blinded to the results of the IFR, so nothing was done to these lesions, and now we're looking at 1-year outcomes, and I'll tell you about what they found. And then once we get to the discussion section, then I'll briefly, like, mention what the plan is to do with this in the future. And Dr. Ahmed already, like, alluded to it when we were speaking about the when we were doing the introduction. Is that good, Karthik?
Yeah, that makes sense.
Okay.
Yeah,
sure.
So most of these patients had single vessel disease, right? It's just like 10-15% multi-vessel disease. Many had looks like LAD disease was like 60% of the population. So definitely a large proportion, and this is known from prior studies that a large proportion, about a fifth to a third in various studies, have abnormal hemodynamic findings, either FFR or IFR after PCI. So all right, go ahead.
Yeah. So the at baseline, the Seattle Angina Questionnaire, the angina frequency score was on average around 70 to 75 between the two groups. And the median was 70 for the IFR less than 0.95. It was 80 for the IFR more than 0.95. So the cohort at baseline didn't have a lot of angina, and there was no difference between the two groups. But at 12 months, both groups had an increase in their Seattle Angina Questionnaire score by 20 points, and there was no difference between the two groups. The important finding that they found, they looked at the subset of patients who had frequent angina, as in Seattle Angina Questionnaire of less than 60. And again, those are the patients who are having angina either daily or on a weekly basis. And they looked at the
baseline is what time point?
At the time of recruitment. So
before their PCI, they underwent.
Before the PCI, they administered the Seattle Angina Questionnaire. They did it again at 1 month, 6 months, and 12 months.
A lot of these patients had ACS as well. Right? I guess many registries do it post too. But the numbers again are sort of in line with angina patients, like in the 70s, to have this angina questionnaire.
Yeah.
And another thing to focus is so two ways usually we use this. One is like obviously the absolute score. The higher is better or less angina, right? Higher scores are better. And then the second thing is totally angina free. That's also another thing. John Spertus likes to use these two parameters when describing, the experience of patients. So the no angina portion of it, right? So there were a fourth or so were angina free at the time of PCI.
Yeah. So for the angina free, like at baseline, 1/4 of them were angina free, but at 12 months, 80% had no angina. And there was no difference between the two groups. You can see it here, Karthik, right? So there wasn't a statistical difference between the two groups. But when they looked at the patients who had frequent angina, as in daily or weekly, in that subset, there was like difference between the two groups. Like the p-value was 0.01. Every single patient who had frequent angina at baseline, and the operator was able to achieve an IFR of more than 0.95. Every single patient of those reported an improvement in the Seattle Angina Questionnaire of more than 10 points. In the subset that had an IFR of less than 0.95, I mean, they did a good job. Like almost 90% of those people reported an improvement in the Seattle Angina Questionnaire by more than 10 points. But you can see that there is a difference between the two groups. Yeah.
Yeah, I'm not
As
sure
for-
I would make too much of that.
Yeah.
You know, people who have lower scores have room to improve. So,
Right.
you know, and then people who ended up with high IFRs, you know, I guess among the people who had an improvement to a very good IFR, the ones who had a lot of angina before seem to have complete resolution as opposed to near complete
Right.
for the other group.
Yeah, I totally agree. I mean, you can see the median post-intervention for both groups is 100, which is like no angina. So at least 50% of the patients post-intervention in both groups, they didn't have any angina. So
yeah, they obviously did a great job, you know, with symptoms,
right.
and even in their technique. I was looking at the drift, and they used a drift of 0.98 to 1.02, and literally just a handful of patients had that amount of drift. So, you know, that has not been my experience. So, you know, definitely, they did it well.
Yep, and they also like started from, you know, relatively not that symptomatic cohort, and what they achieved, like, you know, really. Yeah, as for the hard outcomes, they reported here they are showing us Kaplan-Meier curves, and the blue line is the patients who had an IFR, post-intervention IFR of less than 0.95. The red line is post-intervention IFR of more than 0.95. When they looked at the composite of cardiac death, spontaneous MI, or clinically driven target vessel revascularization, you can see the patient who had post-intervention IFR of less than 0.95, they had an event rate of 5.7% at 12 months, as opposed to 1.8% for the patients who had an IFR of more than 0.95 at 12 months. The hazard ratio was 3.4, and this was statistically significant. The more interesting finding is for the composite of cardiac death and spontaneous MI, the cohort who had post-intervention IFR of more than 0.95 had no event at 1 year in their cohort. Like, you know, in this study, 0. And then this table goes over the components of these two composites. Again, we spoke about MACE 5.7% versus 1.8. This was statistically significant. Cardiac death and spontaneous MI was reported at 3.2% in the post-intervention IFR of less than 0.95 versus 0. The spontaneous MI, it was reported more in the IFR of less than 0.95. The periprocedural MI was included in this second composite. The target vessel revascularization is also where there was difference between the two groups. Like here it was 3.6 versus 1.8. Non-target vessel revascularization occurred in kind of similar proportion between the two groups. So in conclusion, despite angiographically successful PCI, highly symptomatic patients at baseline with post-PCI of IFR of more than 0.95 had greater reduction in anginal symptoms as assessed by the Seattle Angina Questionnaire. And we also had a signal of improvement in event-free survival at 1 year compared to patients with post-PCI IFR of less than 0.95. So this is the main conclusion of the study. Just to quickly go over some limitations.
Did they break it down by focal or diffuse? I know that you mentioned they had focal and diffuse. I bet you know, the event curves would be very different for people with diffuse disease or let's say, you know, diffuse disease and less than 0.95 versus those with, I don't know. Is that true? I'm just curious to know.
Yeah, no. So they didn't report the clinical outcome based on whether the post-intervention disease was diffuse or localized. I wonder if they're going to do that in the future. But again, if you look at the event rates, they were like, you know, quite small. So and this is in everybody, so I don't know if it's going to be really informative if like, you know, if they had like just 16 events in these 285, then we're gonna like, you know, how many of those had an abnormal IFR of less than 0.89? So it's less than 285. And within that, you're going to break it into focal disease versus diffuse disease. So I wonder if they are going to have, like, you know, but it's an interesting thought for probably a bigger prospective study in the future. Yeah, but they didn't report it as.
But four out of 5 patients looks like had focal disease, right? And about actually, and 1 in 5 had diffuse disease. So
yes,
most of them just had focal stenosis, residual.
Yes. But just to remind everybody that the initial study that reported the focal versus diffuse disease reported it in the patients who had post-intervention IFR that was abnormal, which is less than 0.89. In this study, they dichotomized the cohort by an IFR of 0.95 because they started the study by drawing a receiver operator curve to detect the best cutoff for detecting clinical outcomes. So, so if you read the initial study, you'll see that the dichotomization happened with an IFR of 0.89, and within that 0.89, 80% of within the subset that had an post-intervention IFR of less than 0.89, as Karthik said, 80% of them had focal disease. So I just wanted to make this distinction between the two studies, and I can show this.
Yeah, no, that's important. That 0.95 is used. This one.
Yeah. So do you still see my screen?
Yes,
you can see the whole screen, or just the.
I mean, I can see your slides, and then list of slides on the left.
Okay, how about now?
Yeah,
you see the PDF?
Yeah.
Okay. So this is the initial report. And you can see that over here, they looked at post-intervention abnormal IFR of less than 0.9 also, 0.89 and less. And here, like, you know, you can see that 25% of the patients had an abnormal IFR post-intervention, and the focal disease was 20%, diffuse disease was 5%. Now, for the location of the focal disease, 1/3 of it was within the stented segment, 1/3 of it was distal to the stented segment, and 1/3 of it was proximal to the stented segment. I can show that. Most lesions were located in the left and they didn't put it in the table, it was in the text. Yeah, take my word for it. So, okay. So few limitations before I open it to discussions. As Karthik said, that this cutoff that was used of 0.95 was identified post hoc, so it wasn't like based on accumulation of previous data that showed that this cutoff is important, and then like, you know, it was tested, or like, it's not that the operators tried to validate it from previous studies. They used the data that they had, and they drew a receiver operator curve, and they came to this cutoff. Probably in the future that this can be validated in some external cohorts. The second thing is, like, you know, when it comes to extrapolating the data to to our patients, it's a little bit high. It's a little bit hard because of a lot of high-risk patients were excluded. So as I showed, like, patients who had severe medical conditions, patients who had chronic total occlusions, patients who had low EF, patients who had, like, severe aortic stenosis, all of these patients were excluded. So we can't, like, extrapolate the data to sicker patients. And then another important issue, like, how frequently can we achieve this post-intervention IFR of more than 0.95 without increasing the risk to the patient? And this will need to be addressed in prospective fashion and randomized trial, which is what the operators are trying to do. So right now, we have this DEFINE-GPS randomized control trial that is kind of trying to answer this question in a way, and they are recruiting. So I'm going to stop over here for any questions and any comments or any teaching points for us, the fellows from attendings.
I think that's a great presentation, Mo.
Thank you.
So obviously, the study shows that the better IFR you end up with, the better the lesser symptoms you may have and have less events. But obviously, it remains to be tested whether PCI driven to IFR goals is of any benefit. And obviously, the additional piece here is of the pullback, and focal disease and diffuse disease, and whether even additional angioplasty is feasible. So a lot of questions which are layered on top, which need to be answered. But obviously, sort of understandable that if you have a good hemodynamic outcome at the end of the procedure, you tend to do better, and often angiography it does not correlate well with it, which was shown by the first study. So, it raises the question whether we should be checking, IFR or FFR after procedures, especially when the angiography is sort of questionable. I think it's definitely helpful.
Yeah, I mean,
Karthik, I would actually, I mean, it's pretty simple to do the pullback. And so, in room 9 or 11, if you're going to do an IFR of any lesion, I think it just makes sense to do an IFR pullback. Only if it's a really tortuous or challenging to cross vessel, would you skip it? But it's one extra picture, and you just have to ask the text to turn on sync vision. And then there's, you want to do it at 15 frames, etc. There's a couple of things that you want to do. But I think this kind of suggests that we should be doing this more often to see how much diffuse disease there is, and what the extent of the disease is.
Yeah, I mean, it's an adjunct, like, we already use IVUS to optimize our stents, and like, many of these interventions we are doing it over the physiology wire. So, we can just, like, reconnect it and measure the post-intervention IFR, and as Sami said, like, we can do a pullback. And
and the first thing is about IFR versus FFR. I think evidence is obviously with this trial and others is accumulating that IFR is just as good, and right. So I think in our lab it's still the go-to thing is probably FFR, but I see a lot of IFR being done these days as well. So definitely we are shifting in that sense, and the pullback really adds an additional benefit or data that we don't get with FFR.
Yeah.
Thanks, Mo. I just have two things. First, just an interesting way to get back across all those tortuous lesions once you've done the PCI is to use a dual lumen catheter, put it over your PCI wire, put the FF wire out. You can pull the dual lumen back, zero it appropriately, place a dual lumen catheter over the wire, then pull it back and remove it back into the guide, and then you can do your pullback. There's some theoretical concerns with vessel straightening from the residual guide wire. So if you wanted to pull that out before you did that, you could do that. So that's one way to recross lesions, because we know these wires are not that maneuverable. The second is it'd be very interesting to see how this plays out, the synergy between imaging and physiologic measurement. Specifically, if you have focal disease, I think probably either is good, although we all know angiography is a very blunt tool. But in these complex lesions where we're trying to maximize, myocardial flow and perfusion, but there's severe diffuse disease, sometimes we've done an IFR pullback, we've stented the most significant lesions, and these are usually a diffuse calcific vessels, and we may end up with an IFR of 0.86 or 0.82, but it's better than the 0.4 we started with. I don't know that that'll ever be tested in a trial because it's competing dollars for corporations, but it's something to think about.
Yeah.
I think the only time you get caught out with I agree with Samit. Every time I do an IFR, I would always do a pullback. It's, such really, really useful information. The only, I think, drawback is that, you can have areas of the vessel that don't have pressure loss across them, but have disease. And so you just have to be a little bit careful, I think, when you plan your PCI, that you don't want to plan, to cover all the areas of pressure loss, but you're still landing in, heavy plaque that's not physiologically significant, but might give you a suboptimal stent result. And, I again also agree with Glenn, if you use both techniques, then you can incorporate them together so that you cover all the physiologically significant disease, but you may end up extending your stent by, 5 millimeters at either end to make sure you land in a healthy segment at either end. And the other interesting thing from the studies that Mo mentioned is that, 20% of that pressure loss is focal and near the stent. So it does suggest that if we do systematic pullbacks after the PCI as well, we're going to identify potentially correctable lesions. It's not necessarily going to be, you have to add, another 48 millimeters of stent to, get your IFR up further. It might be further post-dilatation or, covering edges and things like that. So hopefully when the trial, completes, we'll have, actionable results from it that show that, we can improve our PCI technique further.
Yeah, because we'll be allowed to use imaging for defined GPS, so that 20% intra-peri stent hopefully could be avoided completely with appropriate stent location, size, and choicing.
Are we a participating site?
Yeah, so we're about to launch. We were in contracting for a really long time, and so now it's with the IRB, but we're getting pretty close. We're just kind of planning our site initiation visit. So hopefully in the next few months. And then I totally second what Yusuf just said about using IVUS. You can actually add IVUS to your pressure map. So when you do your pullback, you can then also add an IVUS pullback, which makes it really cool to plan your intervention. So hopefully soon we'll be in this study.
How many centers is it, Samit?
There's 28 right now. There's 2 or 3 that are
group.
really enrolling a lot of patients. And then there's many that are kind of stalled. And so it should pick up in the next year or so.
It's obviously the same folks, Jeremiah's and Greg Stone, right?
Yeah, exactly.
Seems that Duke is also quite involved in it. Yeah.
All right, great.
All right. Thank you, everyone.
Thank you, everyone.
Thanks, Mo. Good job.
Thank you.